Welcome back to the next section of Gastroenterology in our preparation for our endless quest to pursue and master our knowledge base in order to do well on step 2 and to serve a suffering humanity. Inflammatory bowel disease. Both forms of inflammatory bowel disease, both Crohn's disease and ulcerative colitis, have a lot in common. They're both idiopathic disorders that cause inflammation of your bowels. Now, in medical school, they tell us a lot about whether it's transmural or it's mucosal. There's granulomas and there's no granulomas. But let's start first with what do they have in common? Let's start first with what do they have in unity? Because if we see these two diseases as different variants of the same problem, it cuts what we have to memorize in half. Therefore, let's look at these two disorders as different variations on the same disorder. What do they both have in common? They both cause abdominal pain, they both cause diarrhea, they both cause abdominal bleeding, they both cause diarrhea and pain and bleeding, they both cause fever. What do they both have in common? They're both chronic, unrelenting, remitting, and relapsing. They are both chronic disorders of inflammation of the small and large bowel, or just the large bowel, causing weight loss, diarrhea, pain, and fever. And because of all this and the seriousness, weight loss. What else do they have in common? The extra-intestinal manifestations are identical. They both can give you joint findings. They both can give you eye findings. They both can give you skin findings. They both can give you liver disease. I know you've been told that only ulcerative colitis gives you sclerosing cholangitis. I know you've been told that. But they both give sclerosing cholangitis. Not based on whether it's Crohn's or ulcerative colitis, but based on how much is the degree of inflammation of your colon. They both give sclerosing cholangitis, not based on whether they're Crohn's or ulcerative colitis, but based on how much inflammation there is of your colon. If you have colonic Crohn's, you're going to get sclerosing cholangitis. And cholangitis is always going to be from ulcerative colitis. The extra-intestinal manifestations are going to be identical. Uveitis, iritis, pyoderma gangrenosum, erythema nodosum, pyoderma gangrenosum, erythema nodosum. That's a lot in common. They're both diagnosed with barium enema. They're both diagnosed with endoscopy. Both. Now, what is a little bit different? One is that ulcerative colitis is going to be positive for anti-neutrophilic cytoplasmic antibodies, whereas it's going to be negative for anti-Saccharomyces cerevisiae. Woo-hoo! Is that a long name? Saccharin, sweet, myces, fungus, cerevisiae, antibody. Well, A and A, anti-antibody, nuclear cytoplasmic, Saccharomyces cerevisiae. Cerevisiae, like you mean cerveza, beer? That sounds familiar. Yeah. It's the organism that makes beer beer. It's the organism that ferments hops that makes a beer. And that is why Crohn's disease is anti-neutrophilic cytoplasmic antibody negative, but anti-Saccharomyces cerevisiae positive. You see the difference? Positive, negative, negative, positive. That means Crohn's disease has an antibody against the bug that makes beer. Now, what is that beer-making bug doing in your body? I don't know. Now, what's the difference between you not knowing and me not knowing? Well, I have deep ignorance, and you have superficial ignorance. You don't know, but you think somebody might know, or you could find it in a book. Your ignorance is superficial. I don't know, and nobody knows. My ignorance is deep. And that's the difference. We are here today to deepen your ignorance. I don't know and nobody knows why that bug is up your butt. I don't know. So that's just the way it is. How do we distinguish these without endoscopy between these two different disorders? Now, they are both treated predominantly with mesalamine derivatives. Now, mesalamine derivatives can be divided up into several forms based on packaging. Pentasa, you could say it's 5-ASA, 5-acetyl-salicylic acid derivative, 5-ASA, 5-acetyl-salicylic acid derivative. Or you could say it works for all 5 parts of the bowel. Stomach, duodenum, ileum, jejunum, and colon. 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 Ooh. Upper and lower. Stomach, duodenum, ileum, jejunum, and colon. That must mean that this works for Crohn's disease because it works up and down the whole bowel. Okay? 5-ASA or acetyl-salicylic acid for all 5 parts of the bowel. Now, what about this? What about ascol? What part of the bowel do you think that ascol works for? Oh, I'm sorry, I misspelled that. Asacol. Now, what part of the bowel do you think that that works for? Was it better the other way around? It works for ulcerative colitis. Why? Because it's colonic ASA. ASA for the colon. Acetyl-salicylic acid for the colon, or asacol. It works in ulcerative colitis. And the other thing is ROASA, rectal ASA. Rectal acetyl-salicylic acid. This is useful only for the most distal ulcerative colitis. Rectal, ROASA, is for the rectum, ROASA. Pentasa for all 5 parts of the bowel. Stomach, duodenum, ileum, jejunum, and colon. Stomach, duodenum, ileum, jejunum, and colon. Stomach, duodenum, ileum, jejunum, and colon. Asacol, colonic ASA. Rectal ASA. And you might say, hey man, where's our old friend sulfasalazine? Hey, anybody here seen my old friend sulfasalazine? Can you tell me where he's gone? Oh, what's the problem with sulfasalazine? Well, the problem with sulfasalazine is the sulfa. The problem with sulfasalazine is that when you have between 10 and 30% of the population allergic to sulfa medications, this is predisposed to causing an awful lot of... The 3 things you get are the 3 things... So, rash. Well, yes, sulfa drugs giving you a rash, but not just a rash. Drug-induced hemolysis. Sulfa causing hemolysis. Sulfa causing you to have renal problems. Allergic interstitial nephritis. Why, the only reason to take sulfasalazine is somebody says, well, I'd like to pee some eosinophils today. Yes. Well, can I pee some eosinophils? Sulfasalazine, allergic interstitial nephritis. Sulfasalazine. Now, sulfasalazine does exactly what mesalamine does, except that mesalamine does not kill you with sulfa adverse effects. Same efficacy, less side effects. What would you use? The answer is mesalamine. Now, steroids are used in these patients in the same way that steroids are used for acute exacerbations of asthma. Steroids are used in these patients in the same way that steroids are also used for acute exacerbations of asthma. Somebody comes in, they're acutely ill, steroids. Somebody comes in, they're acutely ill, steroids. Well, you recognize it for asthma. I'm more short of breath. I'm coughing. I'm short of breath. I'm wheezing. Steroids. Well, what would be the same thing for your rectum? The answer is, oh, I have greatly increased number of bowel movements today. I have more fever. I have more pain, more fever, more pain, more fever, more pain, more blood. Oh, man, I better use some steroids. Now, which of the following is the most appropriate steroid to be used for people who have inflammatory bowel disease? And the answer is, go on, you'll never get it. The only reason you know is you're looking at the notes. I see you. You're looking at the notes. We want a drug that has all of its effect here in the bowels, but won't affect us systemically. Now, when you use steroids in asthma, you want to use steroid inhalers. Now, steroid inhalers, what would be the equivalent of an inhaler for your bowels? How do you inhale with your rectum? Well, the thing is that you can use steroid enemas. Well, I've done a lot of things in my life, but steroid enemas is not one of them. But the problem is that steroid enemas won't get very far. They'll only get in for the distal part of the colon. So the problem with steroid enemas is that they only work in distal disease, they only work in colonic disease. So how can you have a local effect in the bowel and try not to have a lot of systemic effect? What we would like to do is we would like to use a form of glucocorticoid that provides a prominent anti-inflammatory or glucocorticoid effect. In addition, we wish to avoid systemic adverse effects. Patients with inflammatory bowel disease, because of the inflammation and damage of the bowel wall, have significant malabsorption, often of fat-absorbable enzymes such as vitamin D. Combined with a malabsorption of calcium, patients with inflammatory bowel disease are extremely high risk of developing hypocalcemia and vitamin D deficiency, and on a long-term basis, osteoporosis. Therefore, long-term use of steroids only exacerbates the effect of the malabsorption upon your bones. What we'd like to use is a drug that has all of its effect locally, but doesn't hit the rest of you. It would have to come out of the colon, into the mesenteric veins, into the liver, and never make it out of the liver. That's called first pass effect. First pass effect. It comes out of your colon, into your liver, and the liver detoxifies it first shot. First pass effect. So that means if that drug comes out of your colon, into the superior mesenteric vein, remember here's the splenic vein, superior mesenteric vein, coming out of your colon, forming your portal vein, we want to make it so that after it comes out of the portal vein into the hepatic vein, we want all of that drug too, as it goes in here, to get all detoxified, so into the hepatic vein, nothing goes. That's called first pass effect. The effect locally in my colon, and the liver cleans it all out. Effect local in the colon, liver cleans it out. And that is budesonide.
Budesonide? I never heard of budesonide. Oh, SpongeBob SquarePants goes to medical school. But I never heard of budesonide.
And the answer is you've never heard of budesonide because if you have asthma, you don't want a drug that all gets cleaned out in the liver. You want systemic effect. So if you gave budesonide and it was all cleaned out in the liver, then you don't get the effect on your lungs that you are looking for. Let me hear you. Oh. Satyam Shivam Sundaram. Bahotacha. We are developing knowledge. I was sitting under the Bodhi tree when I developed enlightenment. Right. Budesonide, I want to have cleaned out of my circulation so it doesn't make it systemically. Oh, That's good for colonic disease, but that's bad when you have asthma or a vasculitis or another reason that you need systemic steroids, in which case, if you gave budesonide for them, you'd have a very clean colon in asthma, which doesn't help us very much. Budesonide. Now, the problem with steroids is that if you use them long term, they have all sorts of systemic side effects. They cause cataracts. They cause osteoporosis. They cause truncal obesity. They make you start having a buffalo hump. They give you all sorts of bad things that you don't like cosmetically, not to mention hyperglycemia, cataracts, and osteoporosis. So how do I keep you off of steroids? How do I keep you off of steroids? How do I keep you off of steroids but still have a prominent effect for the anti-inflammatory effect? What can I do to keep you off of steroids but still modulate your immune system? The answer is 6-mercaptopurine or azathioprine. 6-mercaptopurine or azathioprine. These are anti-inflammatory drugs that help keep you off of steroids and keep you off of all the steroid adverse effects. They are never used for acute exacerbations. They're like to keep you off of steroids chronically. They're like hydroxyurea for someone with sickle cell disease. They don't do anything for the acute episode. They prevent the next episode. They're like cromolyn for an asthmatic. They don't do anything for the acute episode. They prevent the next episode. How do you keep someone off of steroids? 6-mercaptopurine and azathioprine. How do I keep you off of steroids? That's what we're going to do. These drugs. Now we have some specialty items here. Ciprofloxacin and metronidazole, the two drugs as the drug of choice for diverticulitis for infectious disease, has some effect on people who have rectal or perirectal Crohn's disease. Perirectal, perianal Crohn's disease. People who have fistulas and fissures and abscesses and other distal rectal disease, when you kill those microorganisms, you can make the disease better. So you can use ciprofloxacin and metronidazole in combination to prevent the perirectal or perianal disease that you might find with Crohn's disease. Well, it looks like I almost said the same thing for almost everything. Mesalamine derivatives, drug of choice initially for both. That's true. Pentasa, acetylcholine, rowasa, you notice ASA, acetyl salicylic acid. They are three different packages of acetyl salicylic acid. It's just a delivery form. That's all. It's just a delivery. Okay? But they're the same basic drug, just different delivery. Drumsticks, chicken wings, breasts, thighs, a leg. It's just different delivery systems. Sulfasalazine does the same thing, but the problem with sulfasalazine is allergic effects, adverse effects. Steroids are used to control any acute exacerbation. Budesonide is the drug of choice because it has tremendous first pass effect, and as soon as it hits the liver detoxifies it. So it doesn't affect the systemic circulation as much. 6-mercaptopurine and azathioprine keep everybody off of steroids. Well, what's the difference between these diseases then? Well, Crohn's disease has a big thing that ulcerative colitis does not do. Crohn's causes fistula. That is a big deal. Crohn's causes fistula formation because Crohn's is a transmural disease. And since Crohn's is a transmural disease, it goes through the wall of the bowel and can poke a hole from your bowel into your bladder. Ooh, how attractive. Can poke a hole from your bowel right through your anterior abdominal wall. It can poke a hole through your bowel to other parts of your bowel. And that's why Crohn's disease is more likely to present with a painful, palpable mass. Transmural through the wall of the bowel into the skin, the vagina, the bladder, all three, fistula formation. The other thing is, that's why we use infliximab. Infliximab is a monoclonal antibody against tuberous necrosis factor. Infliximab is for fistulas. Infliximab for fistula. Infliximab for fistula. Infliximab for fistula. Fistulizing Crohn's closes up those holes. Seals up the connection between your bowel and your anterior abdominal wall. Seals up the connection between your bowel and your bladder. Between your bowel and your vagina. Seals up the hole between those organs. Infliximab for fistulizing Crohn's disease. Ulcerative colitis cannot form a fistula because it's in the mucosa. It doesn't go through the wall, through mural wall, through the wall. Intramural sports, within the wall of the school. Transmural, through the wall. So it's not transmural. This is through the wall. This is only in the mucosa. Can't form masses, can't form holes. Which of these? Colon cancer. Which one? I heard you. You're thinking ulcerative colitis. And that is the wrong answer I'm looking for. I'm looking for you to say ulcerative colitis because I'm looking for you to be wrong with me here now, where it doesn't hurt, where you don't live with the consequences, where it's just another anonymous educational contact. Because it happens to be that both Crohn's disease and ulcerative colitis can cause colon cancer if they have involvement of the colon for greater than 8 to 10 years. If you have Crohn's that involves the colon, you can get cancer. Ulcerative colitis always involves the colon. But if you have Crohn's of the colon, you can have cancer. It depends not on whether it's Crohn's or ulcerative colitis. It depends upon the duration of the involvement. And if you have the Crohn's causing 10 years of colonic involvement, it causes the same risk of the colon cancer. And you should scope. Boom, boom, the scope. You scope after 8 to 10 years of inflammation. Now, infliximab has an adverse effect that's been associated with it. Infliximab has been found to reactivate tuberculosis. Now, why that is, no one is sure. All of a sudden, your immune system gets activated because tumor necrosis factor gets controlled with the infliximab. And what we have found is that some people reactivate their tuberculosis. Maybe it's that those TB organisms are stored inside your macrophages for years. Maybe they're lonely. Maybe they just wanted to come out from looking for friends. I don't know, and neither does anybody else. The point is, infliximab causes reactivation of TB, and the point is, you should test with that PPD to prevent the TB as you're going to start the infliximab. The use of infliximab has been most commonly associated with A, neutropenia, B, a rash, C, liver disease, D, reactivation of tuberculosis. Prior to the use of infliximab, you should A, check liver function test, B, check a CBC, D, check a chest x-ray, E, check a PPD. PPD. I knew you could. Did you say PPD? I thought you could. There we go. Now, how do I know that people will make mistakes like think that the Crohn's disease is not associated with colon cancer and only the ulcerative colitis? Because mistakes are reproducible. That's what we know. That's what we know. We know that the mistakes that people make all over the world are essentially reproducible. So the point of putting you into this circumstance is to get you to make those mistakes now where it can't hurt anybody, yourself and those people we're going to take care of someday. So the idea here is to make sure that you're put in a position where you're forced to choose. If you're mistaken now, that is good. Because the whole idea is not that you have some unique sin. Everybody always thinks that their sins are worse than the other person's. We always think that we're somehow especially cursed or worse than the others. It's not so. There are very few unique sins. Okay? In reality, Walt Whitman is correct. He says, I am larger and better than I thought. I did not know. I am larger and better than I thought. I did not know that I held so much goodness. Your mistakes are reproducible. We come to drain them out. Both Crohn's and ulcerative colitis gives colon cancer, not based on whether Crohn's or ulcerative colitis, but on duration of inflammation of the colon. Both Crohn's and ulcerative colitis give sclerosing cholangitis, not based on whether the Crohn's or ulcerative colitis, but the duration of inflammation. It's the inflammation duration, not whether they're Crohn's or ulcerative colitis. Those are the two most common mistakes. So you don't have unique sins. There are very few unique ones. That's why you only need 10 commandments. If there were so many unique sins, well, we'd have to have 7,000 or 8,000 of them. You finish those first 10, and maybe we'll get you 10 more. But there's very few unique, unreproducible mistakes. Everybody's making the same ones. You do surveillance colonoscopy after 8 years. Infliximab has been shown to reactivate tuberculosis. Why? I have no idea. Sulfasalazine does the same thing, but sulfasalazine will cause more allergic reactions. And why should I get the same efficacy with more allergic reaction? Ciprofloxacin and metronidazole will treat perianal disease. Crohn's disease is perianal. Ulcerative colitis tends to stay just in the main body of the colon. What else is different between Crohn's and ulcerative colitis is that ulcerative colitis is curable with surgery. Curable? Uh-huh. How can you cure ulcerative colitis? You're going to cut out the mucosa? Do a colectomy. Colectomy? Collect-you? Colectomy? Yeah, colectomy. You can't have colitis without a colon. Yeah, that's nice, but I'd hate to see what your treatment for erectile dysfunction is. What am I going to do without a colon? No problem. Do you know that we can make a new rectum out of your distal ileum? You can stretch the distal ileum. So you can make a new rectum out of a distal ileum. So therefore, you might not like your colectomy, but it's a lot better than sitting around waiting to see whether you get colon cancer, isn't it? I guess so. Ulcerative colitis is curable with surgery. Crohn's cannot be cured at surgery. A patient comes with Crohn's. They get surgery to relieve a stricture. What will most likely happen in the future for the person who has Crohn's, who has the surgery? Answer: recurrence at the site of the original surgery. The question: what happens if you do surgery for Crohn's? The answer: that it will recur at the site of the surgery. The question: which one of these should get surgery? The answer: Crohn's disease never gets surgery. Ulcerative colitis can, because no colon, no ulcerative colitis, no cancer. Crohn's should not be treated with surgery. The only exception is a stricture. The question: what happens when you operate on the stricture? The answer: it recurs at the site of the surgery. The question: oh me, oh life, what good amidst these, oh me, oh life? The answer: that you are here, that life exists, the powerful play of life goes on, and you may contribute a verse.